We're going to talk a little bit about melanoma, and Clay and I are going to do a little tag team session first on melanoma, and then we're going to do it on dysplastic nevi. So I'm going to be more on the clinical side of things today, and we'll talk about risk factors, diagnosis, and management, and these are my disclosures. And the slide's not advancing for some reason. Is this working? It's loading, okay. Okay, there we go. And a lot of this is covered in our textbook, Cancer of the Skin, and many of the speakers have been authors of some of the chapters of the book, so I thank them. So we're going to talk about really these 5 factors: epidemiology and risk factors, prevention, a little bit on prevention, diagnosis, removal, and treatment of advanced disease. We're really going to focus today. So let's talk about incidence of melanoma and why this is important. Just to remind you, there are more skin cancers than all other cancers combined in the United States. And to look at the data from 2014, it's estimated there'll be a little more than 76,000 newly diagnosed cases of invasive melanoma. This is where we are in 2014 in terms of lifetime risk for invasive melanoma. This is across all Americans, about 1 in 53 at the current rate. And should that continue, it'll be about 1 in 50 and next year and 1 in 40 by 2020. So despite everything we're doing, that incidence of melanoma continues to increase. If you add to that 76,000 invasive cases, so the estimated 63,000 in situ cases, put it all together and do the math, the lifetime risk of getting any kind of melanoma in the U.S. is now about 1 in 24, so a significant public health problem. This shows you what's happened to incidence in the U.S., and there's some subsets of the population that have been progressing more quickly. Young white women, and that's probably due to tanning salons, and older white males because they've already had so much damage, you can't undo what they've done. And as my wife said, you can't teach an old dog new tricks, whatever, so never argue with my wife. Certainly, this data set is the same. You can take any data set in the world, but the overall ratio of melanoma males to females is about 4 to 3. Nobody knows why that's so, but that's true in every data set. This is data from the American Cancer Society, and you see that melanoma is the 5th most common cancer in men and the 7th most common cancer in women right now. It's not just a disease of Caucasians. The data shows that it's been rising in non-Caucasians. This is data from Hispanics in California, and you can see that the incidence has been increasing there. The good news is that the survival rate for melanoma has been increasing over time, but the only reason for that is because of earlier detection. It's not for any other possible reason at this point, at least. And as we see with melanoma, the early detection is absolutely critical because the earlier you catch it, you can make an impact. Once it's advanced, basically nothing, almost nothing works. We'll talk about some potential treatments. People do die of melanoma. It's estimated that about over 9,700 Americans will die from melanoma this year. And what is unfortunate, although the number of thin lesions is rising more rapidly than the number of thick lesions, the number of thick lesions is still rising. So despite everything we're doing with early detection, we still see more and more thick melanomas presenting, and that's what's causing the increase in death. And this is just looking at the incidence of invasive melanoma. This is the mortality rate over the last 10 years or so, and you can see it's going up despite everything we're doing. And this is, again, just looking at the raw numbers, and you can see in the last 9 years, again, this is kind of our report card, and I'd say we probably are not getting the best possible grade here. We'd like to see that go in the other direction in terms of mortality from melanoma. Now, this was a paper that came out about earlier this year, and it was kind of an interesting one where they looked to see the density of dermatologists per county and how that related to melanoma mortality. It actually turned out as the more dermatologists you had in a county, the lower the melanoma mortality rate was. So mortality is related to early detection. And this is actually the map that's from that one of the papers of the Furler paper. And it basically, as you can see from this, that I don't think we have Eagle County. I guess Eagle County is a blue one in there. But you can see that we can make a difference, thank God, as dermatologists with this. So let's talk a little bit about risk factors. And clearly that person flashing there is at higher risk. The blonde person's at somewhat higher risk. But the fact is that there are some other factors we can predict who's going to get at higher risk for getting melanoma. The presence of dysplastic nevi, and we'll talk about that in the next section, so I'm not really going to go into that too in depth. But do persons with dysplastic nevi get melanoma? That's the key question. And this is actually a case from a patient I was asked to do a consult on. And I remember this patient because it was on the neurosurgery service, and it was the day before the academy meeting. I was getting ready to go and leave, and they wanted, this person had been in the hospital for a total of 11 days and some various things, and nobody had looked at his back or reported it. So the day he was leaving, they said, we'll get a derm consult. I think everybody would recognize it, even a neurosurgeon should recognize there's a problem there. So when you look at the risk factors for melanoma, dysplastic nevi are high up in there, but there are a whole bunch of other factors that are there, and certainly they're usually due to either phenotype or environmental exposure. A prior history of non-melanoma skin cancer gives you about a 3-fold increased risk for getting melanoma. Melanoma is associated with some other cancers. There's probably a genetic overlap that we don't know yet. Risk of breast cancer is about a 3-fold relative risk. Personal history of prostate cancer gives you a slightly elevated relative risk. They're about 1.83. And again, we don't know why. This was an article in the archives a couple of years ago. Certainly, if you have a prior history of melanoma or other non-melanoma skin cancers, but prostate cancer and a bunch of other cancers, eye melanomas, thyroid cancer, lymphoma, leukemia, all these studies that are out there show this relationship. It's not a big relationship. Typically, the relative risk is on the order of about 3, which is about the same as having red hair. So, but it's there, and we don't quite know what the genetic relationship is, but it's clearly there. Now, this is data from last year from the Minnesota Department of Health, but we could use any data set, looking at the incidence of melanoma in men and women, and you can see it's increasing. But if you just look at people from age 20 to 49, you see that almost all the increases in women, while it's actually pretty much flat for men in that group. And the difference between that, when you look at demographically, is probably exposure to tanning beds. And tanning beds are a serious problem. I think all of you in this room know that. Heard what the Surgeon General did about a week and a half ago, talking about a call to action for the country the first time this has happened. We're very fortunate that the acting Surgeon General right now happens to be a dermatologist, Boris Leshniak. So while he's still the acting Surgeon General, we'll get hopefully some advancements on this. This is just to show you the number of studies out there, but as you'd expect with a carcinogen, you expect to have a risk of multiple melanomas, and this study shows that those who go to tanning beds have an increased risk of getting multiple melanomas, not just the initial melanoma. This was a paper that came out that showed the association of IBD and melanoma. Again, these are small relative risks, 1.2. You find it because the number of cases are so big. Nobody knows what this means, but this is a second study to show that. Aspirin use and melanoma risk. This was interesting because 5 studies, this is a review, 5 studies showed a protective effect and 4 studies showed no protective effect. So I'm not quite sure what that means. It may also mean that people who take an aspirin a day also have other healthful behaviors and protect themselves from the sun. This was an interesting study that showed that people have argued that high vitamin D levels may in fact protect you from melanoma, but this did not show that in this large study. So that was one of the arguments the suntanning industry makes. As you'd expect, in the United States, there's a slight propensity towards a few more melanomas on the left side. That's probably due to driving. You see it more with men than you do with women, but again, probably when they're both in the car, a man may be driving a little more because he doesn't want his wife to drive. My wife can tell you that. We do see melanoma, as I mentioned, in non-Caucasians, and this is just a series of some cases. It is there. What's really of interest here is when you see them, they're typically on sites that are not necessarily exposed to the sun as much as they might be. So plantar, palmar kinds of things. And there may be more than one flavor of melanoma. And I think when we have this meeting 5 years from now here, we'll have some more answers about that because we treat melanoma as one disease, but it probably isn't. We see a higher incidence in transplant patients, as you'd expect, given the fact that they're immunosuppressed. And if you adjust for immunosuppressive therapies, what you can see is the stage of melanoma that you see with this, and is associated with these kinds of transplant patients. Melanoma is associated with socioeconomic status. These are the 3 terciles of counties in the U.S. by income, and you see that the highest income counties have the highest rate, but over all sets of counties, the rate is still increasing. And if you look at survival and socioeconomic status, basically, the more money you make, the more likely you are to survive from melanoma, and that's probably due to earlier detection and better access to early melanoma biopsy. Let's talk a little bit about photoprotection and sunscreen, and most people think this is a nice picture, but of course we know we have to protect. As this woman finds out, she gets too much sun, and all of a sudden she gets a melanoma on her back. But we know that, in fact, if we could block that sun with some kind of sun protection, we can lower the risk. So are sunscreens effective in lowering melanoma risk? And the answer to that is, for the first time, there is a paper that was done prospectively to look at this. And you can see this was done in Australia with Adele Green, who's a melanoma researcher there. And they took 1,600 people, and they randomized them to either daily sunscreen use or discretionary, usually when they felt like it. And they treated them for 5 years and then followed them for 10 years subsequently because of the latency. And here's the data. Those who used the sunscreen when they felt like it, compared to those who used it daily, the daily people had about half the chance of getting melanoma in that period of time. If you looked at just invasive melanomas, they had about a fourth the chance of getting melanoma than those who used the sunscreen when they felt like it. So for the first time, you can tell your patients there is a study out there prospectively that shows the regular use of sunscreen lowers melanoma risk. This is also an interesting series that was done where they looked at what happens to people who are diagnosed with melanoma. How does their sunscreen usage change? And what it turned out is that for the first year after using sunscreen, what happens is that so first year diagnosed with melanoma, you're more likely to use sunscreen. But after a year, it goes back to what it was. So this is a good argument for why we as dermatologists have to keep reminding our patients to use sun protective measures. And this was actually a follow-on study of that study, looking at the second year of follow-up, that actually people were getting more UV than they were prior to having their melanoma diagnosed at 2 years out. So again, that continuous education is important from our point of view. This paper was a disturbing one that came out, and this was in the archives last year. And what they looked is in how many visits, what percentage of visits did dermatologists mention sunscreens? They looked at all physicians, but a subset of dermatologists. And the data they showed for dermatologists, only in 1 in 60 visits, did dermatologists mention sunscreen to their patients. I don't think that's true. I mean, I think we all mentioned a little more. So what we had, this is actually the data from the study. It was going up a little bit on time, but still 1 out of 60 is ridiculously low. So we actually just completed a study. This is my fellow, Rich Winkleman, and we finished this study about 2 weeks ago and are just putting it together now. So you're the first to see this. But we sent an email out to 6,700 dermatologists in the U.S. We got a 530 response, or a 9% response rate. And we asked 2 questions. How many patients did you see in your last 2 days of practice? And with how many of them did you discuss sunscreen? And it turned out that of this series, that we got a 58% answer in terms of the percentage of people we discussed sunscreen with. And most dermatologists recommended anywhere between F30 and 49, and then the next level is 50 plus. Here's actually the data. It's kind of interesting. Overall, that 58%, a little bit higher in the southern third of the U.S., but not by much. If you looked at years in practice, actually the younger colleagues were more likely to discuss sunscreens as opposed to the older colleagues, and that was actually statistically significantly different. If you looked at the types of SPF recommended, you could see that the older colleagues were more likely to recommend a higher SPF than the younger colleagues were. So there were some differences. And also, if you looked at the vehicle preference, there wasn't much difference. Still, even most people had no specific preference for vehicle. But of those who did, as you got older, I guess set in your ways, I guess. So you had more suggestions of what you liked. But what is interesting, as of last year, for the first time, the number one formulation for sunscreens that are sold are actually sprays. Number one, more than anything else. So sprays are hot right now. So we talk about melanoma. Let's talk about detection. And why is early detection so important? I think all of you know this graph that basically survival is directly related to early detection. So we have this patient comes in. This is an unusual presentation, people we see every day with multiple lesions. How do we know which is the melanoma here? So how accurate are we as dermatologists in diagnosing melanoma? Well, this is a series of studies that are out there. We think we never miss a melanoma, but probably we're right about 80% of the time. And there was one study that showed 94%, but you could see they went with thicker melanomas in the study, so it was a little easier to diagnose. But almost every study out there, we're about 80% right. We're better than everybody else, but we're still only about 80% sensitive in finding melanomas. So how could you do a study to determine this? It's hard to do the perfect study because you'd have to take a bunch of patients and decide whether to biopsy them or not biopsy them and then biopsy them. So typically what's done is something called a reader study. And what that is this is one study that we did, and you would get, this is the short version of it, but you'd get 3 images, a distant, a close-up, and a dermoscopic. And then I would ask you, is this a melanoma or not? So how many of you think this is a melanoma? Raise your hand. All right, how many don't think it's a melanoma? Okay, if you don't raise your hand, you can't bill for the consult, so you have to kind of one way or the other. So the answer is, in fact, it is an early invasive melanoma. And this is typical of the kinds of things that are in reader studies. Not an easy case, but it's a challenge, but we face these challenges every day. So a bunch of these studies I mentioned, they're all in that 80% range or so with this. What's also interesting, if you have multiple dermatologists, what you'll find is they all get it about 80% right, but they pick a different 80% subset when they look at it. So the perfect diagnostic tool would be a room full of dermatologists and take the majority vote. And that, in fact, would be the best way. Again, it'd be tough to build that one out, too. So how has the diagnosis of melanoma evolved over time? Well, in the 60s and 70s, we looked at frank symptoms, bleeding, crusting, whatever, and I think everybody would recognize that this is a melanoma. In the 80s, we started with the ABCDs of melanoma, and that's our group at NYU developed them. I can't believe it's almost 30 years ago that we did this with Al Koff and Bob Friedman and myself and published the paper. And it's obviously, everybody in this room knows the ABCDs. This is the actual paper that we published in 1985 in CA talking about this. And of course, to the ABCD, we added E in 2004 for evolving because change is also so important. Now, this template has been validated in a bunch of ways over time, so it works with this. And we moved on to dermoscopy, and then beyond dermoscopy to computer-aided diagnosis. And we did a review article. You're getting old when they ask you to write 25-year retrospectives. So we did a 25-year review article of the ABCDs and how melanoma diagnosis has evolved. And there are a number of other technologies. Confocal microscopy is one that's out there to help with it. And again, that's a confocal microscope. You can see the difference between normal keratinocytes versus atypical melanocytes. And Clay's going to go more into pathology. Certainly, confocal does work with a high sensitivity. Multispectral digital skin lesion analysis, which is Melifine, which is next door. This is the original pilot study that was looking at it. It does it looking at a number of small wavelength bands, comparing them, and looks at the data to determine if the lesion is worthy of biopsying, basically. This was the pilot study that was done in the JAD when the technology was first developed. And with this pilot study, there was 100% sensitivity and 85% specificity on the small pilot. This was the definitive study that was done in the pivotal trial that was published in the archives. And with this data, the device had a 98.3% sensitivity versus the dermatologist. The group had about a 72% sensitivity for this, which was good. Another way of looking at it, all the blue squares are the dermatologist, and the red dot was Melifine, and you can see Melifine did as well as the 4 best dermatologists. So again, these devices can enable us to do better with additional information. There are a number of them out there. This is from the paper I mentioned earlier, a number of devices. These are a number of devices that are being worked on also and looked at, so we're not quite there yet. This was an interesting study. It was done in Austria with expert dermoscopists, and they compared dermatologists who were good dermoscopists with primary care physicians who had a computer system. And it turned out that even with the computer system, the dermatologists were much better than the PCPs with the computer, and that's because the PCPs didn't know which lesions to image. So you still have to have a good set of eyes to determine what are the right lesions to image, even with a computer system for this. So there's some other studies. This is another study, give another example of a reader study. And we went through and did a study looking at these kinds of patients and trying to make it a little more realistic. So we had a virtual patient that had multiple lesions as opposed to just individual lesions. So in this one, we did this study and we asked, would you biopsy this lesion? And you look at it, you can think about that to yourselves. And then we gave people the information from the device and then said, now would you biopsy the lesion? And the idea was to see how much influence did the device have on your biopsy decision. Now, we published this in the archives 2 years ago. This was from Winter Clinical. We had 179 derms in the study. And what was interesting, there were 5 of the 24 lesions were melanomas. Here's the sensitivity pre-getting the Melifine information, and here's the sensitivity post-getting it. So you could see that having the information, 2 things, it improved your sensitivity, but also people didn't follow the machine blindly because they would have had 100% for each one of these things. So people still use it as part of the biopsy decision, which is the correct way. We did the same study on resonance. In fact, that's one of the posters that's out there right now. And you can see that residents got better having the information also, but they weren't as good as attending. So there is some hope still that experience does have some value. And this is the reverse. Those are the lesions that came out as suggesting they didn't need biopsy, and that the values dropped. But notice they didn't drop to 0. Again, people still determined that it was a piece of information, but not the be-all and end-all. So this is actually an interesting one that we just did, and we just putting this together for publication. We did this in June. This was at the dermoscopy meetings in Maine. I don't know if any of you were there. But we did actually a variant of the study, but we showed first the clinical, then the dermoscopic image, and then the Melifine information. At each point you were asked, would you biopsy the lesion? So the idea was with the marginal information from dermoscopy and then the marginal information from Melifine, would that make a difference? And these were all, obviously, at a dermoscopy meeting, expert dermoscopists talking about this. So there were 30 plus derms, and there were 30 plus non-derms who were primarily PAs and NPs who worked in derm offices and did a lot of dermoscopy. Again, 12 lesions, 5 of which were melanomas. So here's actually, you're the first people to see this study too. If you look at the dermatologist and non-dermatologist, it's pretty close. But what you see in all these things is that dermoscopy may help just a little bit in these people, but getting the Melifine information dramatically improve the sensitivity. So this is the sensitivity. The specificity also gets better for both groups, and it gets actually a little worse after dermoscopy. These are the low-grade dysplastics in the series. In other words, those that didn't have to be biopsied, actually the biopsy rate went down as you'd want it to after having the information. This is what's called diagnostic accuracy, which is the combination of all those factors improved after having the information without much of an improvement with dermoscopy. And this is the number of people choosing to biopsy all 5 lesions, and in fact, as you see, that goes up dramatically too. And the overall number of lesions biopsied, though, stayed pretty much the same. There wasn't much change. So what that tells you is you were biopsying about the same number of lesions, but you were finding more melanomas and choosing not to biopsy more non-melanomas, which is what you want. So you had a higher biopsy accuracy rate, or your biopsy ratio dropped, and I know Clay has a poster about that outside there. So again, from the study, it looks like that even beyond dermoscopy, these kinds of devices can have a significant influence. This was a funny paper that was out there about smartphone applications. We all have patients who come in now with something on their iPhone that says, I can diagnose melanoma. And it was interesting. This was reviewed on four different apps. And the one that was 98% correct was the one where you take a picture and send it to your dermatologist. So I'm not sure how much software is behind that, but the other ones were basically worthless at this point. So I'll talk briefly the remaining time about removal. And certainly we know that if you shave through a melanoma, it turns out that it's not really a problem so much, although the pathologists get upset with it, but you may not be giving the pathologist enough tissue to accurately stage this. And in the majority of cases, it was predictive, but in 5% of the cases in the series, shave biopsy wasn't enough. And also punch biopsy could be problematic. In this series that was in the archives, they basically, in 23% of the cases when a punch biopsy was performed, you got a false negative when it actually was a melanoma. So sometimes just those punches, the big lesion, may not give you the right result. In terms of removal, surgical wide excision is obviously the goal, and you don't see a lot of this anymore. These are the old 5-centimeter margins with a split thickness skin graft. This guy actually is a patient of mine. He developed a little psoriasis on his skin graft, which is kind of interesting. But certainly we talk about how wide is wide enough, but really, we really want to know how narrow is too narrow, and that's almost impossible to determine at this point. This paper came out recently suggesting that 5-millimeter margins for melanoma in situ may not be enough. And this is from the University of Pittsburgh, and John Zitelli, who's been a big advocate of 1-centimeter margins for melanoma in situ, and he showed that in this particular series that 6 millimeters were only adequate 86% of the time. People are still using 5 millimeters, but it may come into question, although this study has been criticized in some ways. But these are the current margins for melanoma. Sentinel lymph node biopsy, I'm not going to spend a lot of time on with this, but it is the most important prognostic factor. You're going to hear about some more prognostic factors later this morning with genetic issues. I won't go into that right now, but tumor thickness, when you look at ideas about how can you predict who's going to have positive nodes, this was an interesting study showing that basically here's by thickness, the thicker the melanoma, obviously the probability of a positive lymph node goes up. This was a study that looked at thin melanomas trying to determine who would have a positive lymph node. 4 factors, older than 43 years, thicker than 0.8 millimeters, tumors on the lower extremity and trunk, and low numbers of TILs. All 4 of those factors, if you had them in a thin melanoma, you had a 30% chance of having a positive sentinel node. So the idea how to determine who to detect, who to do sentinel nodes on, and again, you'll hear more about this, some other techniques this morning. This was the big trial that came out in the New England Journal earlier this year. And the idea behind this was looking at melanomas that were thicker than 1.2 millimeters and looking at 10-year disease-free survival rates. And this is actually the data from it to show that the sentinel node biopsy patients, for the first time, this is a long-term study, did better than observation, as you can see, for both survival and disease-free survival. And for these are for comparing intermediate melanomas and thick melanomas, same thing, although in this case you didn't see quite as much of an improvement with this. But they concluded from this that it does prolong disease-free survival, and it does prolong a distant disease-free survival and melanoma-specific survival in those who had intermediate thickness melanomas. So it's just the first time you can tell patients they do get a benefit from sentinel node biopsy. There are complications with sentinel node biopsy. Most common one is a seroma, a wound separation infection, but they're relatively low. So these are the current guidelines that are with ASCO for a sentinel node biopsy. And it's the most important thing is there's some controversy. If you have a positive node, do you complete the dissection and take out the remains of the nodes? That's been put to rest by these typical recommendations. Now, the last minute or so, I guess we're running out of time here, so I will just go through this really briefly. But advanced disease is an issue. And this is actually a patient of mine who was so proud of himself. He took this picture with his iPhone. Unfortunately, this was about 10 months before he came to see me, because when he came to see me, it already looked like this on his foot. And this is the result of what he had to have done. 11 months after this, you can see he has the satellite met right there, and he actually is expired from metastatic melanoma. So clearly, we have to detect it early, and there's not a lot of really good treatments for advanced melanoma. That's a close-up of the met. So vaccines have been worked on, and the problem with vaccines are that the surface antigens of melanoma are constantly in flux. So if I were to take all the antigens and put them in the lab and mix them up and develop antibodies to those antigens and re-inject them, the idea behind that is I would have the right antibodies, I'd lyse the cell, and I'd treat the melanoma. Unfortunately, the surface antigens of melanoma are constantly in flux. So if I were to do this, by the time I inject the antibodies, the reality is that, in fact, we'd be injecting yesterday's news. So people try to use a polyvalent vaccine approach. They take a smorgasbord of all the most common antibodies, re-inject them, and the idea behind that is you may hit on them, but you may not get the concentration you need to do the job. So those are the challenges when you look at a vaccine antibody type of approach. Now, if this was 2010, this would be the end of this lecture. But of course, what we have now is targeted therapy for melanoma. And in fact, when you have multiple targets out there, we're getting better at identifying them. I'm just going to talk, there's a bunch of these, I'm just going to talk about B-Raf inhibitors because that's the thing that's really the most important that's out there right now that we see most of. And the idea is that there are multiple pathways in melanoma, but the B-Raf pathway is the one that the mutation is found in about 60% of melanomas. And it's only one mutation. There's a glutamine that's substituted with a valine. That's it. But what that does is it keeps this pathway switched constantly in the on position. So these inhibitors basically block that pathway and turn it off, and that's how they work. The idea that you must have this B-Raf mutation for the B-Raf inhibitors to work, so you have to take tissue and have it taken from, it come from the block to have this COBAS test done, which is important. This is the test, this is the approved, and there's about a 97% agreement with the presence of the mutation with the test. So very important to do. This is the drug that's typically used at this point, the most commonly used one. Here's the paper from the New England Journal. It showed it improves survival. This is a plot you can see with the drug over time compared to dacarbazine. It did quite well. This is progression-free survival, even better. And again, I won't go through the whole thing with this. I do want to show you, this is, I'm going to skip through it, and I apologize, but this shows you just through this, but I wanted to show you this one thing. This is important because about 1/3 of patients on this drug, Zelboraf, in fact, get Ka-like squamous cell carcinomas. And typically they appear primarily in about 2 to 8 weeks of treatment. And they come out and they have anywhere from 1 to, I've seen 6 or 7. This is why it's important as we as dermatologists are following these patients at the time. And you can see about 1/3 of the cases with this. This is actually a plot of when the SCCs appeared. So you see it's front-end loaded from the time of initiation of therapy. but it's important they be looked at and treated, and they're removed like any other KASCC would be removed with it. This is what they look like. So I'm going to stop at this point and turn it over to Clay because we get involved with pathology, and we can talk more about treatment and everything with it when we get to the Q&A part. Thank you very much.
Okay, so we're going to talk about like what's kind of new in melanoma diagnosis and prognosis, and these are some of the things we're going to talk about. These are all in your handout. So to start with, let's take a look at things where you can overdiagnose melanoma, the so-called sheep and wolf's clothing. And again, sometimes the old saying that the hedge is the pathologist's favorite flower, well, it is. In some cases, you do need a hedge, but we want to try to give specific diagnoses. And I always tell my fellows the 3 bears, Goldilocks approach, not too hot, not too cold, just right. And so we want to learn where there are situations that can simulate melanoma, but they're not, where you don't really need to hedge. And site-specific nevi, they get some unusual features that can simulate melanoma. There are a lot of these sites that we see this. Probably the most common are the flexural areas, the groin, the breast. This is the axilla. And again, these lesions tend to have larger nests of melanocytes. They may have a slight degree of pagetoid spread. They don't have mitotic figures, not striking atypia, but you do see some of these features and sometimes be a little concerning to the dermatopathologist. The genital area, very common to sort of simulate melanoma. Again, they get these large nests with abundant cytoplasm, no mitotic figures. The lesions overall architecturally are benign, but because of some of these cytologic features, you may get back some recommendation to remove this. I remember an unfortunate case a few years ago where one of these was called a melanoma. They sent it to me, and I said I thought it was just a benign site-specific nevus. They did a complete labial excision on this young woman when she was in her 20s. So you just have to be careful of overcalls. The back also has some interesting features. You tend to get these nest of melanocytes that tend to coalesce, and they form this kind of almost syncytium of melanocytes at the dermoepidermal junction. There's usually minimal pagetoid spread, and you can get some fibroplasia. These look very much like dysplastic nevi, and when you look at these, we're going to talk about that a little bit later. But again, it's easy to overcall these as melanoma. No mitotic figures. Again, they're symmetrical and well circumscribed architecturally. Acral lesions characteristically will give you some pagetoid spread. Ron Rapini referred to these as so-called maniac nevi because you get these zones where you get some pagetoid spread. But again, this is just a common simulator, and you just have to understand that this does not mean melanoma. So you must correlate these lesions with clinical features. They're small, symmetrical, and everything, and they have some of these features not to worry. And nevi on the ear, interestingly enough, always very commonly look like Spitz's nevi. They get these atypical cells. They're slightly atypical. They're somewhat epithelioid and somewhat angulated. And we had a case a few years ago that was diagnosed as a desmoplastic malignant melanoma on the 20-some-odd-year-old guy who was a CEO of the Las Colinas Sports Complex in Dallas. And clearly, he was worried that he was going to have his ear cut off and nodes. They sent the biopsy over for consultation. It showed these kind of changes, these spitzoid features, which you see very, very commonly in lesions on the ear. They're small, they're symmetrical, they have other features of malignity. So if it doesn't look like melanoma and it comes back from one of these special sites as melanoma, get in touch with the pathologist, say, I want to get a second opinion, and just don't accept it as gospel. Congenital nevi, interestingly enough, sometimes you'll see some single melanocytic proliferation that can simulate melanoma, and if you get a lesion in a young kid, you can get these proliferative nodules. These are not malignant, so you have to know how to diagnose these. So here's a relatively small congenital nevus, again, benign, very symmetrical. But if you look at the epidermal changes, you've got these single melanocytes with some cells above it, and I get consultations, not infrequently, where somebody has taken a nice Sharpie and drawn an arrow pointing at this, and I just say, I always tell my fellows, ignore arrows, stay away from them. So, and if you send me a slide that you've written on, I'm going to send it back to you with a nasty note. So, no drawing on slides. But this is something that can simulate melanoma. You just have to realize that it's benign, and it doesn't mean that it's melanoma. This is usually seen over the obvious dermal congenital nevus component. Now, if you biopsy congenital nevus shortly after birth, usually within about the first, maybe 8 months or so of life, sometimes up to a couple of years, you can get striking pagetoid spread that can really simulate melanoma, again, histologically. But this is a normal phenomenon. These cells are migrating through the epidermis. They eventually, if you biopsy this thing at 5 years of age, you may see just a few of those little single melanocytes that I showed you before, and this is not malignant melanoma, and certainly you don't want to call it melanoma, and you don't want to sign it out as atypical horrendoma, and then the mother gets panicked and everybody ends up getting a wide excision. So again, look for maturation, symmetry, all of those features. Even though you have these changes that can be somewhat, quote, worrisome, there's no mitotic figures, no striking atypia here, and just have to realize this is a normal phenomenon that can happen in these lesions when you get it shortly after birth. So again, nests predominate over single cells, no atypia, no mitotic figures. Proliferative nodules, these can be scary. You get these large nodular aggregations in a congenital nevus. Usually these are in the large congenital nevi, but usually we see these in kiddos, but they can occur in adults too, interestingly enough. So this is a sad situation because, you know, when melanomas develop in congenital nevi, it's usually these kind of nevi, and you can't excise these. You can size, you know, things like this, but something like this is just almost impossible to get rid of, or something like this. And this was a kiddo that presented with this was an actual melanoma that arose in a congenital nevus in this situation in a young child. But if you look at these, they generally tend to be large, but they don't have a lot of atypia. They may have a few mitotic figures here and there. They usually allow up to 1 to 2, and then they also demonstrate maturation. You don't really see any pagetoid spread in the overlying epidermis. So here's a congenital nevus, and these cells, again, quite typical in appearance, but here's one that had one of these proliferative nodules in here, and another one, and these are heavily pigmented. Again, the nodule themselves generally tends to be fairly symmetrical and round when you see it under the microscope. And you may see a couple of mitotic figures, but when you see it in the setting of a congenital nevus in a very young child, proliferative nodule. And we'll talk later on about genetic testing that may be able to do if you're really not sure. Here's another one that was not as heavily pigmented. Notice in the background of a giant, large congenital nevus. The cells, again, are relatively, they're proliferating. It's a separate clone of cells, but they're not really strikingly atypical. There are no significant numbers of mitotic figures. So again, you can diagnose these, and you don't have to call them melanoma or hedge them. There is some biologic difference. Again, some comparative genomic hybridization studies have demonstrated some chromosomal changes that are somewhat similar to melanoma, but if you take these things and put them in tissue culture, they don't grow like melanoma. And if you actually inject them in mice, they don't grow like melanoma. So they're kind of interesting lesions. We do see these on occasion, and again, you have to just understand the limitations of what you see on these various things under the microscope. Ella talked a little bit about this yesterday, so I'm not going to talk a lot about it, but for those of you who do Mohs, it's important to realize that if you start using immunoperoxidase stains, these things are so sensitive, they will pick up anything it even thinks about being a melanocyte, and it can lead to you cutting out a lot more than you need to. And this was melanoma in situ, but notice all the background sun damage this guy has, and unfortunately, it's very hard to tell where this ends and where this stuff begins. And another example, again, all this modeling in the background. So if you do a biopsy and you see this is melanoma in situ here on sun-damaged skin, proliferation of single melanocytes involving the follicle, so it's pretty straightforward. If you put MART1 on it, just like Ella showed you yesterday, it's going to be strongly and diffusely positive. Well, this is a solar lentigo. This is not a melanoma. It's seen in somebody that's got a lot of sun damage as well. This is a keratinocytic process, so there's pigment here, but there's no real increase in the number of melanocytes here. So this is not a pigmented melanocytic lesion. It's a pigmented lesion, but it's benign. And if you put a MART1 on that, it looks the same. So if you're cutting one of these that's got a melanoma in situ and it's got a contiguous solar lentigo, like these two pictures I showed you before, you're going to keep cutting. And you're going to get a bigger hole than you need to. So be careful of using these techniques. And even if you use the other techniques like SOX10 and whatever, personally, I just think the best thing to do is I like to use a Woods lamp. I'll show you how we approach these. So here was a real world case we had that was sent to me in consultation, and the Mohs surgeon sent it and said, gosh, is this, I can't seem to get clear margins. And to me, this just looks like a solar lentigo here with some background sun damage and not really melanoma, but they had put a MART1 on it and it was positive. And they said, well, it's confluent and all this stuff, so I think it's still melanoma. It wasn't melanoma, but they kept cutting and cutting. So just beware of using these extremely sensitive techniques that pick up things more sensitive than your eye. It's kind of like going to the Dallas Cowboys Stadium and looking at that screen. That's an enhanced image, and you won't watch the football game because you're watching the stupid screen. So you don't want to do these techniques that are too sensitive. They can guide you in the wrong direction. So what do? Well, we recommend taking a Woods lamp, outlining the true extent of the pigmented lesions, and then take a 5 millimeter margin around that. If you still have melanocytes at the end of it all, you can recommend using post-surgical imiquimod, but just be careful of using these HEV45 MART1 stains. So here's an example, pigmented lesion, Woods lamp, so you can see it's more heavily highlighted here. highlighted, they mark it off with, during the Woods lamp, so they take the marker and do it during this photograph, then take a 5mm margin around that, and then they've got the true margin. So now this is new information now, and I know Darrell's going to want to get these slides, and he's welcome to them, because this is brand new information that just came out of a study that was done by one of our former residents, Brandon Lintzner, looking at is 5mm margin really enough for melanoma in situ? And it turns out it really and truly is. And a lot of Zitelli's papers were based on referrals, tertiary guys that had difficult lesions to get rid of and eradicate. But this is a really good study that's in the process of being published. I think it's going to help us with this, because it documents that 5mm for what we do in our practices is really enough, and we can treat these in our offices. So where did melanoma margin start? Well, it started with Handley back in 1907. And they believed that melanoma grew like a crab. They thought this was contiguous spread. And they used to recommend excising the melanoma, and all of the skin between the melanoma and the lymph nodes, including the lymph nodes, were removed. So these were some of the surgical types of specimens that were done back in the 1900s early. They would take these gargantuan, like radical mastectomies for melanoma. And so basically they thought that they didn't understand that cancer cells spread through lymphatics. They thought it was spreading contiguously. So that's why you still have surgeons think you can excise Mets and they actually are going to cure the patient. Well, these are the guidelines that Darrell showed you. I won't really talk about that. And again, this is a Zitelli study which showed that you really need to take more. But actually, this slow-mo's technique, again, they found that you can really get these off with a couple of stages, and you really don't have to take these giant excisions. So, but we've noted in our laboratory over the years that we don't get a lot of positive marks for melanoma, maybe 10% or less. And they're not taking a centimeter, they're taking 5mm. So our experience didn't jive with what's been reported in the literature. And so perhaps it's due to referral bias, maybe overinterpretation of solar lentigo. And actually, I did hear someone that trained with Zitelli give a talk not too long ago, and they showed a lot of solar lentigine stained with HB45 antigen and called it melanoma. So I think that could possibly be a reason for this. But Brandon did this really good study. And what he did is he looked at patients and looked at melanoma in situs, and some of them were early invasive melanomas. And these were kind of the patients that he saw. They were very similar to those at Zitelli, so similar demographics. And they used the Woods lamp technique that I just showed you about a minute ago. And they actually had a scalpel that sort of had two different blades, so they were excising the actual edge of that melanoma and then 5mm around that, and then engrossed it in an en face fashion like Mohs. And basically what we found was that if you just looked at whether there was residual disease in the excision after the biopsy, now this is post-biopsy, only 29% actually had residual melanoma in situ left after the clinician had taken a deep, broad saucerization biopsy. So most clinicians removed most of the melanoma with their biopsy. They only had one that was outside of the clinical margin that went about 0.85 centimeters beyond the clinical margin. If the ones that had the little melanomas, the thin melanomas, 20% of those, again, had residual disease, none of those outside the clinical margin. So those that had the, quote, positive margins on their shaved biopsy specimens, the melanoma extended to more than one or more of the edges of the specimen. 88% of those with residual disease had positive margins, but 11% of those with negative biopsy margins had residual disease. So this suggested, again, that most of it had been removed with the biopsy. 95% of the cases were cleared using a 5mm margin. So that does not jive with what Zitelli's telling us. So I don't know why there's a difference, but this is kind of what we're seeing in our lab. So I think this is more real world, that you can take 5mm margins around these and you're okay. So that's reassuring to know that it actually works. So let's shift gears and talk about where melanoma is less serious in its appearance and it really is deceptively benign. This is the dangerous situation. So somebody comes in with something like this, it's got a little zone of regression, and you do a biopsy and it shows this melanosis here with minimal melanocytic residual proliferation. Well, this is not necessarily a good thing. You know, regression of melanoma, it's sort of controversial in the literature as to whether it's a good prognosis or bad prognosis, but sometimes it can be subtle. This guy also has got a melanoma here that is undergoing early regression looking like a halo nevus. So again, some of these can be deceptively benign both clinically and histologically. Only a few melanocytes focally above the dermatological junction here, but plenty of regression. So again, can look less serious both clinically and histologically. Now this is, in the opposite view, this is an example of a benign lichenoid keratosis that underwent regression. And so sometimes you'll get back a note from your pathologist that says complete regression of possibly melanoma. Well, this is why, because if a regressed lichenokeratosis looks very similar to regressed melanoma. You get this melanophage deposition here, you get some fibroplasia with a little bit of lymphocytic infiltrate here, and again, it can look very similar to complete regression of melanoma. So you need to understand what the limitations are. If clinically it doesn't look like it, and histologically we see a little zone where there's a little background solar linigo or macular seborrheic keratosis, that's the way out. But if you're not sure, you may have to go back and re-excise. So sometimes you'll get that from your dermatopathologist, and that's why. Occasionally we see lesions that look like blue nevi, and we think of them as either cellular nevi or combined blue nevi, but they're actually melanomas. And again, this is something where, as we'll talk about a little bit later on, genetic testing can help you out. This lesion, again, looks kind of like, it's obviously nodular malignant melanoma. This was a 25-year-old woman that had this lesion. It looks fairly symmetrical. They did a punch biopsy. We started looking at it. Really wasn't much going on in the epidermis, but down here, some of the cells were a little bit larger, and she actually had some ugly mitotic figures interspersed within this thing as well, as you can see here. So actually, this was an example of a blue nevus-like malignant melanoma. We recommended that a sentinel lymph node biopsy be done, and it was positive. It was just with sheets of effaced atypical melanocytes. So those lesions can look like blue nevi. They're really melanomas. Beware of some blue nevi that this was a blue nevus-like malignant melanoma. We've talked a little bit about the poorly differentiated spindle cell neoplasms. Not going to really spend a lot of time on those. Again, just to show you that if you get squamous cell carcinoma, atypical fibroxanthoma, malignant melanoma, they can all look the same basically under the microscope. We used to, when I was a fellow, we used to bet with Dr. Ackerman whether it was going to be a melanoma or AFX or not, and we just didn't have any immunostain, so we'd say, well, if it's contiguous with the epidermis and it looks like it's got some squamous differentiation, it's probably squamous cell, you really do need these stains to tell them apart. We were probably about 45% accurate just in guessing, but we used to treat these lesions pretty much all like a melanoma until we had these stains that can kind of help us apart, and this one was a squamous cell, so just remember that. Now, this lesion comes into us as rule out basal cell or squamous cell carcinoma, and this, I know I don't have to ask you to raise your hand, but I know that every clinician in this room that's been in practice for more than about 5 years has seen a case that they didn't believe was melanoma clinically, and they got back the diagnosis melanoma. So melanoma can be capricious, and it can be capricious under the microscope as well. Here you see this lesion. It looks like it could be a squamous cell carcinoma. It's verrucous, and look at higher magnification. It's got this atypical component here. It's got these squamous elements here. This looks a little different than this. You say, well, it's probably a poorly differentiated squamous cell in this area. And so this is what it looked like clinically, ulcerated, maybe a little pigment, possibly from the bleeding and whatnot on sun-damaged skin. Well, we decided to do immunostains, and this is an immunoperoxidase stain to cytokeratin highlighting the background epidermis and those cells in the dermis. But notice that it wasn't highlighting these areas, okay? Never just do one stain, okay? We always do a few additional stains when we're working up one of these atypical lesions like this. Well, this is an S100 protein, strongly positive here, negative in the cytokeratin areas. And this is an example of verrucous malignant melanoma. It's a clinical and histologic variant. It can simulate squamous cell carcinoma, dangerous lesion. Make sure that you take a biopsy that's going to allow that to be diagnosed. So again, remember, take representative biopsies. This lesion will keep you up at night, okay? Desmoplastic malignant melanoma, again, seen in older individuals, usually on sun-damaged skin with linigo malignant overlying it, but not always, okay? And I've got a couple of examples of that where I'll show you. S100 is positive in the majority of cases, but I've had a couple of cases over the years that were S100 extremely weakly positive. And so we're using SOX10 now in some of these cases as well. These can easily be misinterpreted. And this was a tragic case that I was involved with a few years ago. The guy had a prior biopsy that was called a nevus. Then we ended up getting this specimen, and you can see it's a dome-shaped lesion. This was an excisional biopsy. It looks symmetrical at low magnification. You go to higher magnification, it's got these, and again, it looks white because there's really not much pigment in here at all, and this was due to the fact that there was a fibromucinous stroma here, and notice there's nothing in the epidermis. On a higher magnification, you can see these delicate spindle-shaped cells and this fibromucinous stroma here, and this was signed out as a neurofibroma. And it sure looks like a neurofibroma. It really doesn't have any features here, to me, that I can say this is malignant melanoma, just looking at these slides here. Multiple sections were reviewed, and he did have one tiny area with melanoma in situ over this area. And this is not that patient's slide, but this guy, another case of desmoplastic melanoma, this is what it looked like in the patient. So how many times have you seen people in your practice with the solar keratoses on their scalp and you're freezing those, and somebody here said that this thing felt a little funny and it was more indurated, so they decided to do an incisional biopsy, and lo and behold, it turned out to be a desmoplastic malignant melanoma. So you got to be aware of this lesion. Be careful of relying on special stains too much. This lesion also, this poorly differentiated, again, we talked about spindle cell lesions and soft tissue lesions when they present in the skin. They don't look like typical lesions. So your diagnosis here would be, I'm not sure. And when we get these things sent to us, they're usually sent in with a differential that sort of tells they don't know what they're looking at. Well, this was the original punch biopsy of this lesion. And again, it shows this spindle cell proliferative lesion. And it's very low grade. This one maybe had a couple of mitotic figures, but again, very few. And this lesion was stained and originally S100 protein negative. And sometimes the biopsy staining is different than the excision stain. We see that all the time. I don't know why, but it happens. CD34 was negative, but actin was maybe a little positive. And they said, well, it seems like it's positive, so I'll call it a leiomyosarcoma. Well, the good news is they at least called it a cancer. And they went back and re-excised it, and this is a re-excision specimen. And lo and behold, now it's got these little lymphoid aggregates that we see characteristically in desmoplastic malignant melanoma. It's again got this fibromucinous stroma like the case I showed you before. And the stain this time was positive. So it turned out the re-excision stain was S100 protein, so final diagnosis here was not leiomyoma myosarcoma, which is a very non-aggressive lesion, by the way. It was this entity, again, which can kill the patient. Here's another one. So probably more in one day than you've seen in your whole life, but just remember this thing doesn't look like a melanoma. I know Jack Cohen's in the room. We had a case of this a few years ago that fooled everybody, ended up in court. So just have to be aware of this very rare entity. Again, clinicians don't think of this. They're going to take a punch or a shave, and it just shows the same kind of features as the others, this delicate spindle-shaped stroma. And if you see this, it's helpful, but sometimes it's not there. The only good news about this lesion is that sometimes it behaves better given its thickness than other types of melanoma. That's the only good thing about it. Everything else is bad about it. So just remember it. And I can tell you, I've had 4 cases over the years diagnosed by good dermatologists sent in to me as cysts. So don't throw away cysts. Beware of lesions that you think of as cysts. It can fool you. The pagetoid neoplasms, again, there's a family of these. We talked about Merkel cell yesterday. That can give you a pagetoid pattern. Again, if you see these pagetoid lesions, you got to exclude the diagnosis of Paget's disease, melanoma. So once again, as Ella said yesterday, you're going to do immunoperoxidase stains. Here you see some ductal involvement beneath there. So this was mammary Paget's in this case. And this is an immunoperoxidase stain for carcinoembryonic antigen. Cytokeratin 7 is a good stain for that. And then let's talk just for a couple of minutes about biopsy technique. Now this is very important because you need to be able to take a biopsy that's going to give you a representative specimen. So let's say you come up on one of these desmoplastic melanomas, make sure the biopsy you do is going to be enough so we can make a diagnosis. I don't like superficial shaves. Saucerization's okay. I don't like punches, believe it or not. That original punch, that leiomyosarcoma, that was taken by punch. It didn't allow us to look at the breadth, the symmetry, and the circumscription. And so you got to be careful. The reason I don't like punches is because it can induce this phenomenon that I refer to as biopsy sculpture. It makes things look small, symmetrical, well circumscribed, because the punch is a nice little piece of tissue. But unfortunately, it doesn't allow us to look like we're looking at the mountains and see the horizon and the vista. So this biopsy was taken and submitted to one of the best dermatopathologists in the United States. And it ended up in a court situation, and they called me to look at it, and this was the original punch biopsy, and say, well, it seems like it's small, it seems like it's symmetrical, there's no epidermal involvement, cells are very epithelioid, and they called this a nevus. Didn't call it a malignant melanoma. And then, of course, the dermatopathologist's nightmare is 18 months later when you get this specimen, or you get another biopsy, and it shows an obvious melanoma now. And so if they would have had a good, deep, broad saucerization biopsy, they probably would have made the diagnosis initially. They would have picked up these areas where there are mitotic figures and more atypicality. So this, you may have heard me give this talk before in different fashions. It looks like a flower, like one of these nice mountain flowers out there. It's actually the fuse of this bomb. So you got to be careful about this, and be super careful if you're in love with curettings, because curettings are notoriously prone to sampling error. Another medical legal case brought to me, unfortunately, a few years ago. This was signed out as epithelial hyperplasia. This was taken near acral skin. The patient was thought to have dermatophytosis, had been being treated by a podiatrist, and then they sent him to a general physician who did this biopsy, very superficial fragmented specimen. If you look carefully, you can see there's some melanocytic proliferation here, but it's very, very subtle. This little fragmented goo contains a nest of melanocytes here that's almost impossible to see. And in this one little tiny piece, there was actually a diagnostic area here of melanomas. So unfortunately, that diagnosis was made because he developed a lymph node metastasis, and then they diagnosed him. They went back to this retrospectively, and unfortunately, the poor pathologist ended up having to settle the case for a lot of money. So again, just beware of this. So curettages, if you're going to do them, just realize you're kind of on the thin ice. Nail unit melanocytic lesions, again, you got to get back to the nail matrix. Surprisingly, we see melanocytic lesions of the nail that are discordant to what you see clinically. Now, here's a melanoma in the nail unit, and this is the type of biopsy you want to do. Go back and reflect back the proximal nail fold, get in here, do a punch or an incisional biopsy. This guy did a great punch, beautiful, but he missed the diagnosis. He didn't sample the matrix. So he probably just got back some kind of nondescript diagnosis. So you've got to get back in here to the matrix where they've got the Hutchinson sign going on. Longitudinal melanonychia, we get a lot of biopsies of this. People are worried about it. This does not have the Christmas tree finding of the broader area here and the tapering distally. This has got a very symmetrical, it's just as wide at its base as it is at the end. This is just a simple lentigo, just showing a proliferation of these melanocytes at the dermatoplastic junction with no real significant increase in the length or size of the dendrites here. So we see that all the time. It's highlighted with a Fontana-Masson stain, or you can do an S100 protein stain. We get a lot of these that come to us, racial pigmentation, and you say, well, gosh, there's got to be a lot of color change here histologically. If you look at this under the microscope, it's almost like a freckle. It's hard to see any pigmentation here. Even if you do a Fontana-Masson, you just see a few little sprinkles of melanin here. So there's a discord between what you see clinically and histologically. And interestingly enough, this is an obvious melanoma that no one would have any trouble diagnosing. You biopsy this, and it doesn't look as bad as you think it would look. It's got just a scattered number of single melanocytes here at the dermal junction. There's really no pagetoid spread. There's some maybe hyperchromaticity of some of these nuclei. But you say, gosh, that's obvious melanoma. It really ought to look horrible under the microscope. Well, it often doesn't look horrible. So my rule of thumb is for looking at nail unit pigmented lesions, unless you're doing a lot of these, if you're just doing if you're kind of like the dermatopathologist du jour once a month, you shouldn't be looking at these. You should send them all for consultation because they're all difficult. And here's the S100 protein. You can see these dendrites here extending all the way through the epidermis, and that's a sign of early melanoma in the nail unit. So again, you got to be wary of that. And this is another thing that kind of is a prickly thing to me. Is we're getting back reports from a lot of pathology labs that measure how far your excision goes from the last melanocyte on the slide. There's no data for that, zero. And if you get it, you probably ought to tell them, don't report that again, please, because it makes it seem like you didn't excise enough. But they get that, I think, from the breast cancer world. And again, we don't need to do that because things shrink when we put them in formaldehyde. And you've already taken a 5 millimeter or 1 centimeter margin. So you don't need this. And in fact, to me, it's bad, and it makes it seem like you didn't excise enough. And I don't like these either. You know, I don't like menu-style reporting. You know, they're good in restaurants, but they're not good on a report because the one reason is that they're sometimes wrong, but that legitimizes it. It gives kind of a pseudo-legitimacy to it because it looks cool when you're looking at it. It looks like, you know, they've really done a lot of work on it. But my rule of thumb is that, you know, the longer the report, the greater the number of stains, usually the less is known. And a corollary to that is the further away you send something in consultation, the more dogmatic the report and the more wrong it often is too. So, but anyway, this is an example of one of these. And so it looks great. Turns out it was benign. They totally missed it. So we saw it in consultation. We downgraded it to a dysplastic nevus. So again, you just have to be wary of that. Now, the last couple of minutes, we'll talk about prognostication in melanoma. And again, this refers to our ability to predict things, which has been the holy grail of melanoma. And I think we're getting close, because if we're going to talk about a little later on, there's some genetic tests here that are going to be possibly useful to us on this regard. And again, the first sort of technique to try to do this was Clark using his levels in the 1960s, and Breslow followed it up with thickness. But if you look in the literature, there's tons of stuff in here related to prognosis. And this this grows every day. And so, again, I don't know what all these things mean, but if you look at them in the literature, you see this over and over again, that this is associated with better or worse prognosis, and maybe it'll be useful in the future, and that's the conclusion. Usually when I get those to review, I say, let's not publish another one. There's too many. So I usually recommend rejection. But AJCC, they want us to look at a slide and prognosticate. And again, this is a kind of a primitive subjective deal here, because a lot of these things are not like taking a blood test. Surgeons think they are. You know, they think that looking at a slide is like ordering a blood test, but it's not. These are subjective things that are based on review. And in the old days, before they changed AJCC a few years ago, they liked Clark's level. They kicked it into a higher stage. But they recently recommended don't use Clark's anymore because it's not an independent prognostic variable. Well, I still like Clark's measurements, because what if you get a level 2 that's 1.5 millimeters? There's probably a mistake there somewhere. It's probably either a level 4 or 3, or it's a 0.1 millimeters. So I've seen a lawsuit over a decimal point error before as well. So I like it. I think it's a good check. But just remember that these are not precise. You can send a lesion to different dermatopathologists and you get slightly different measurements of melanomas depending on who's looking at it. So these are not like doing a blood test. These are the Clark's levels, and this is level 3, papillodermis filled, and there's one melanocyte here. So this is 3 and that's 4. Can you really tell that? You know, you really can't. So it's pretty subjective. So this is a level 3 lesion that is totally filled with papillary dermis expanded, and a level 4. And we have a lot of people that call these level 4 when really they're level 3, because the papillary dermis expands like it does in Sweet syndrome and polymorphous light eruption and those kind of things. Now, ulceration melanoma, again, this, if you read the literature, it sounds great. Ulceration present or absent. Well, what if it's traumatized? That doesn't mean anything. No one has ever really, except the Australians in this one study, tried to sort of figure it out, and they call it infiltrative, attenuative, and traumatic, but it's hard to tell these apart. So what if somebody's got that lesion like Darrell showed earlier on their sole, and they stub their toe on the way to your office, or somebody's biopsied it before, and then it gets called ulceration. So ulceration, if it's really there, it's a sign of tumor necrosis. The tumor's outgrowing its blood supply. That's probably important. But if it's just traumatized, it means nothing. And so you got to be careful, because the surgeons think that's really important, but there's a lot of mud in that water. And this paper Paul Googe published a few years ago looking at ulceration and thin melanomas, just the final conclusion here is that thin melanomas, the true primary ulceration, are very rare. Beware of overcalling, because the surgeons will just dump that into a higher stage, and that's not really appropriate. So this guy had a thin melanoma that was traumatized, and this guy had a true necrotic melanoma. These are two different animals. But if you look at AJCC, they're the same animal. So that's one of the reasons I don't like AJCC very well. And I don't like it because of this mitotic figure business either, because again, they talk about counting 5 fields and looking for the hot spots and all, but nowhere in the AJCC do they describe the morphology of the mitoses. They don't talk about the location of the mitoses. In pathology, we talk about, is it at the base of the lesion, is it the center of the lesion, are they in the epidermis or not? None of these are addressed. They just want a number. So they don't want to talk about anything else other than numbers. This got a really thick melanoma with no mitoses. Are you going to tell him he's going to live happily ever after? Well, if you do a genetic test, maybe you might. This guy had some very thin mitoses. They were bipolar at the top of the lesion. This one's got an ugly mitotic figure, but it's in the epidermis. So again, these are just some things that weren't addressed in the AJCC, so it's kind of simplistic. But, you know, the AJC is kind of like the 10 Commandments. And, you know, if God would have been sort of hedging in the 10 Commandments, said, well, it's okay to kill every now and then, or you kind of have adultery if you want to, sort of on weekends, you know, then the commands be a little different. So if you're going to be AJCC, they need to be sort of firm, and they need to be, and those have been around for thousands of years. They change these things every few years. So again, we actually did a prospective study that was recently published looking at mitotic figures in thin melanomas. We found them to be extremely rare, and that unfortunately there are medical centers around the country, if they have one mitotic figure, send a lymph node biopsy. So again, we think that's overdoing it a little bit. Regression, we talked a little bit about this. There's a paper just recently published in Omar's American Journal of Dermatopathology talking about the fact that regression is a good finding in melanoma. So again, this is very controversial. If you see complete regression of melanoma, that can be a bad thing. And we noticed this back in the 60s and 70s. Patients would come in with a lymph node, metastatic melanoma. You look for the primary, and here it is in the lymph node here, and you wouldn't find anything except maybe this, a little whitish gray area, and you biopsy that, and it's complete 100% regression of melanoma, and that was the primary. So in that situation, it probably means that melanocytes got into lymphatics or blood vessels and induced an immune response, and then they got a metastasis. But you can't necessarily take that and extrapolate it to a thin melanoma that's got some inflammation in there and maybe undergoing partial regression. So again, in complete regression, it may not be a good thing, but in a small partial regression, it's probably not necessarily that important, and it's still very controversial. So do we do a service when we prognosticate? Well, this book published by this guy, Christakis, a few years ago, these couple of quotes that I always like to point out here. One of the doctors says that the only thing he can say about prognosis, you're bound to be wrong. And then this story of a 71-year-old patient with metastatic adenocarcinoma, probably from the colon, came in. They gave her less than a year to live, but she fought it, and she lived. And the attending died of a heart attack. That gave her the bad prognosis. So 6 years later, she comes in smiling and saying that she outlived the doctor. So, so she lived for 6 years after her 6-month prognosis. And this guy's kind of interesting. There's actually a little young guy that Darrell knows that lives out here that's kind of got a similar story. This fellow basically had a horrible type of cancer, and he's been around the world, and he's climbing mountains and all this kind of stuff now. But at age 13, he was diagnosed with stage 4 Hodgkin's. He lived through that and fought that, and then 2 years later, he had a fast-growing Askin tumor that was diagnosed. He was actually given 2 weeks to live, read his last rites, but he fought and lived through that. And here he is, like 20-some-odd years later, and he's climbing mountains. So again, you got to be careful with prognosticating, because people will basically they'll beat the odds in many cases. So our litmus test is basically, is it going to be treatment's going to be different, it's going to improve, and what can we do to help them? And this quote from Hamlet: well, there are more things in heaven and earth that are dreamed of in our philosophy. Well, there are a lot of things in prognosis in melanoma that affect things here that are dreamed of in our philosophy as well. And there's been some recent studies to show that immunity has a lot more to do with it necessarily than looking at the number of mitotic figures in a lesion. And so I always like to say that the microscope is not a crystal ball. And this paper published in this Modern Pathology not too long ago, they actually talk in here about the fact that things alter in the lymph node, and that predicts whether they're going to metastasize or not. So again, immunity is important, and we're going to talk about this a little later, but this gene expression profile and some of the other tests, the tests that Myriad does, this doesn't just look at the melanoma genes only. They're also looking at immune genes. So this is the first opportunity to kind of take the entire patient and look at the genetics of the whole patient and see how it's going to interact with their cancer. So it's exciting stuff that's going on, and there's going to be some good things about this that we're going to be able to use in our practice in the very near future.